Hello, everyone, and welcome to the Sudanese Infectious Diseases Association Grand Round. We're pleased today to have Dr. Yasser Hamad join us in a talk about a case today. Dr. Yasser Hamad earned his medical degree from University of Juba College of Medicine in Sudan. He completed his internal medicine residency at MedStar Harbor Hospital in Baltimore, Maryland. Followed by fellowship training in infectious diseases at University of Pittsburgh Medical Center and in critical care medicine at the National Institute of Health Clinical Center in Bethesda, Maryland. Dr. Hamad's research interests focus on infectious complications in critically ill and immunocompromised patients, hospital-acquired infections, and the use of point-of-care ultrasound in the intensive care unit. He currently practices in the medical intensive care units at the University of Minnesota Medical Center and Fairview Southdale Hospital, where he is also actively involved in medical education for internal medicine residents and pulmonary and critical care fellows. Dr. Hamad is one of the directors and a leading member spearheading the establishment of the Sudanese Infectious Disease Association, SIDA, which aims to advance infectious diseases education, research, and collaboration across Sudan and beyond. He is also a member of several professional organizations, including the American College of Physicians, the Infectious Diseases Society of America, the American Thoracic Society, and the Society of Critical Care Medicine. Welcome, Dr. Yasser, and we're looking forward for your case. Please go ahead.
Thank you for having me, Mr. Dean, for the nice introduction. So today we'll talk about an interesting case that I helped in taking care of this patient while doing my fellowship in critical care at the National Institutes of Health. And since we have some pediatric ID people here, we picked a patient who is a teenager, so I guess can relate to both sides of the field. So we have a 17-year-old male who presented to us with dysphonia. His story started when as a child growing up, he had primary combined immune deficiency. And then when they tested him, they found that he has the RAS-related C3 botulinum toxin substrate 2, LIRAC2 gain of function mutation, which is resulting in both humoral and cellular immunity deficiency. And I don't know how can it looks like it's marching on its own. Okay, I think I can pause it. Okay. So as a child, he had multiple complications, including recurrent herpes simplex, as well as zoster infection, sinusitis, pneumonias. And because of his recurrent infections, he was actually offered and underwent a stem cell transplant as a curative procedure for his immunodeficiency. And he had a haploidentical hematopoietic stem cell transplant 6 weeks prior to his presentation to the ICU. But unfortunately, that was complicated by steroid refractory GI graft versus host disease and eventually graft failure, which necessitated the need for a second transplant. Otherwise, he was not going to make it. He presented to the ICU. The main reason initially was he was getting basically hemorrhagic shock from severe hemorrhagic cystitis and AKI as a result of BK virus infection. And then as his initial graft failed, he underwent the second transplant in August 13, 2021, preceded by total body irradiation and myeloablative conditioning, including cyclophosphamide. So very aggressive regimen to reduce the chance of a second GVHD. His post-transplant course, in addition to what we mentioned, was also complicated by HSV stomatitis, as well as chemotherapy mucositis, which the combination wasn't really nice. He also had the hemorrhagic BK virus, cystitis, and pyelitis, requiring multiple trips to the OR by urology to evacuate clots. And then he had a fusarium pneumonia. It's kind of like possible pneumonia. I guess his sputum culture was positive for fusarium, and given his immunocompromise, even though the CT really didn't show any significant consolidative or nodular changes, but he ended up developing. He ended up getting treated for it. I think Ahmad, I don't know. It's advancing by itself. Should I maybe stop and restart? As a dean and technical help here.
We're saying history of present illness now in the slide.
Yeah, but once in a while it kind of advances.
No, it's for in our screen we're seeing it.
Okay.
It's not advancing. Yeah.
So he was getting started on IV ambisome for that, and then he also developed staph epi, bacteremia, and multiple sets, but that was responding to daptomycin. In addition, as I mentioned earlier, to the cytopenias and graft failure. Other than that, his past medical history was really not significant. He was a junior in high school, enjoys playing basketball and video games as a pet dog. Family history of non-Hodgkin's lymphoma, but otherwise really no other significant exposures. So, giving a little bit of a background of the HSV stomatitis course, and kind of putting it in perspective, he was transplanted in the end of June, and by the time we saw him was kind of like early August. So he in July 8th, they noticed the stomatitis while he was on prophylactic PO cyclovir, so they switched to the IV. But then a few days later, or I guess 10 days later, noticed no improvement. So they added IV foscarnet, and he actually did respond to that, but he developed an AKI. So, and since he was kind of improved, stabilized, so they decided to save his kidneys and switch him back to higher dose of acyclovir, like 10 milligrams per kg. While on that, they noted some non-resolution of the lesions and added topical cidofovir about 2 weeks later. And that was the time of the second transplant when he got really significant chemotherapy and radiation. And in the next, after the second transplant, his lesions progressed and his new lesions. So IV foscarnet was restarted, and then it continues to worsen. So ended up adding also topical imiquimod to his regimen. His physical exam at this point showed like he was having low-grade temp and tachycardic, but maintaining his blood pressure. He has significant oral mucositis and ulcers and perioral papules and progressive lower lip swelling, as well as a right cheek lesion. And then he has the three-way Foley in place, which was draining red, kind of pinkish urine with small clots. Otherwise, his exam was unremarkable. His labs were mostly significant for pancytopenias, with neutropenia as well as thrombocytopenia and anemia. But at this point, his kidney function has recovered and has normal liver numbers. So his hospital course was then around the 23rd, which is now 10 days after transplant. He started having raspy voice with dysphonia and increased work of breathing. So ENT was consulted. They did a laryngoscopy. which shows diffuse erythema and swelling of the uvula and retinoids with thick blood-tinged mucus. And then circumferential, now lip involvement with extension to even to the nerves and left cheek. So given the concern about the acute airway obstruction, he was given a couple of doses of steroids, and then kind of this might be a good area to stop and just review the anatomy as we talk about the pharynx and larynx. So the purple part here is what we consider the pharynx, and the green is the larynx. So, and the pharynx is further divided into nasopharynx, which is the top part here in the expanded picture, and then the oropharynx, and then the hypopharynx that leads to the esophagus. And then the larynx is divided by the area of the opening of the vocal cord. This is called the glottis. So above that is called supraglottic area, and below that is subglottic area, and we see here the epiglottis, and the that protects the airway. So keep that in mind as we see. So this is not his picture, this is a much older patient, but it's kind of similar, like the degree of involvement around the mouth and the cheek involvement, as well as his lesions were actually more extensive in the upper lip. As I said, it was kind of almost reaching the nose area. And unfortunately, they continue to progress despite the restart of the Hoarseness. So ENT recommended adding inhaled steroids, but given the HSV, the team kind of held off on that. He already got steroids earlier, which really didn't help. And then in the next few days, his voice was worsening even further, and he was having aphonia as well as drooling of his saliva. So at this point, his IV Hoarseness was switched to cidofovir, concerning for treatment failure. And then when ENT looked, they saw a lot of granulation tissue covering the vocal cords, severe crusting and thickening of the mucosa with all clots in the subglottic region, concerning for HSV involvement and progression. And the ET exam. So I guess this might be a good place to kind of stop and see what do you guys, if anybody wants to chime in and give any thoughts.
So sorry I came late, but so I'm hearing on HSV like resistant. Was there a resistant testing for the HSV, or this was just like, I mean, the switching from acyclovir to Hoarseness was just based on like the lack of clinical response, or was there?
Right. Yeah, I think the resistance was sent, but this was all based on clinical failure of the progression of the disease. I believe his Hoarseness sensitivity later came back susceptible. But I think I might have that in the upcoming slides. Yeah.
Okay, and then one more question: is the picture that you just displayed the actual patient picture?
No, but he looked worse than that. Unfortunately, like it was very extensive lesions, the upper lips and the cheeks, and yeah. And I don't know when you joined, but basically, just to fill you, like this is a guy who had now second transplant, like haploidentical within 2 months after failing the first one and getting ablative chemotherapy, myeloablative regimen. So he was, quite immunocompromised.
Yasir, the diagnosis of HSV is usually clinical.
So he had multiple swabs and like for the vesicles, and PCR was confirmed in those. Yeah. he actually even had, at some point, he was having a little bit of difficulty swallowing, so they did an EGD and nothing in the esophagus, although the brushing came back also positive for PCR, like HSV PCR. And at some point, his blood also was positive for HSV PCR. So yeah, multiple samples were positive to confirm. So I guess anything you guys will do in addition, or to stop the progression, or any thoughts?
Did you get a biopsy, Yasser?
Yes, and I will review that also in the next few slides.
Yeah, so did you mention his blood PCR? Do you guys did quantitative HSV PCR and also what his liver enzymes?
Qualitative, and his liver actually was okay, despite, I kind of worry about that. Yeah. All right, we'll carry along, and then maybe we'll stop in a few slides later. So his, I think the main thing we're worried about, in addition to given the progression of the infection, is that this is progressive and now it's already involving the vocal cords and the upper trachea, and the patient has been showing signs of impending airway obstruction. And so in the next couple of days, he had another ENT exam, which showed ulceration of hard and soft palate, as well as the pharynx, subglottic obstructive tissues. So like when they saw the vocal cords, and under the vocal cords in the upper trachea, they saw like just tissues obstructing the view. And but basically, given that his progressive disease, they decided to intubate him in the OR. So they passed the ET tube just blindly through that kind of area, and luckily it passed. And the lower trachea was relatively preserved, but the upper trachea was almost obstructed by this granulation tissue and inflammatory angry tissue. And I think, as a couple of you asked, like the biopsy, so they did the laryngeal biopsy. And as we see here, there is a lot of neutrophilic infiltrates in the blue areas here, boxes. And then in the yellow, there's more like a necrotic tissue in multiple other areas. And then and another section, you see also neutrophilic tissues, necrotic tissue, as well as HSV cytopathic changes. And then this is kind of like a more expanded view of the same area, with a lot of cytopathic changes of the multinucleated cells and enlarged nuclei. And same as here. We also did the CT scan after the patient got intubated, and if you notice here, from going from 1 to 4, usually the middle here, to orient you, I guess, the endotracheal tube, the bright white color, and then around it is the trachea. Usually you should see a little bit of a space around the trachea as it passes through, but given all this granulation tissue and involving, you can see there is literally it's complete obliteration of the space around the trachea until you get to the lower end of the endotracheal tube, where the airway is patent again. And then, unfortunately, things did not just stop there. And then after we secured the airway, kind of bypassing the area of obstruction, patients start having bleeding from the ET tube and high peak pressures, which indicate there is an obstruction, the ET tube, likely from the clots. And they try suctioning, and just basically bright red start coming up. So he underwent bronchoscopy, and they saw this endobronchial mass. This is about 2 to 3 centimeters above the carina. Let me see if I can run that video. Do you guys see the video?
Yes.
Yeah. So almost acting like a valve, ball valve kind of thing. With suction, it kind of comes up, and then as with increase the pressure, it opens up a little bit, and it was very friable. And here, kind of the bleeding stopped, but we thought that's where the bleeding was coming from. And it's kind of very low. It's almost like just above the carina. So the ET tube was just advanced distal to it, so kind of like tamponade it and bypass it to help with the improving the ventilation. We spoke with thoracic surgery and ENT, and kind of like, would we do a tracheostomy or something? But the concern is that it's quite distal, so it doesn't really gonna make a big difference. So any additional thoughts before I kind of progress to the next slides?
Yes, does he have any cutaneous lesions, or this was just only like oropharynx, or like
CNS? He
cutaneous,
was
skin.
the skin lesions. Yeah, just in the some in the cheek, as I said, but nothing beyond that, like in the other part of the body. So mostly it's like the lips and the mucosa of the mouth and the pharyngeal and the larynx.
Hi, Yasser, Mustafa here. Did you do any PCR on the tissues that were collected
So
initially?
they did immunostain, which was positive for HSV. And I think there is additional biopsies, which I'll show later with that. But yeah, they confirmed that it was.
We wanted to ask about HPV.
HPV.
Yeah.
I mean, usually it causes more like a polypoid lesions, I think, and I don't know if it will explain the picture here, but like with the oral vesicular lesions and so I don't think we necessarily tested for it, but in the clinic it didn't seem to be likely.
How about Coxsackie viruses, Yasser? Enteroviruses.
I think we did like the multiplex and nothing was there, just like RSV, but nothing specifically for that. Yeah.
Thank you.
So, unfortunately, despite the management, go ahead.
There's just like thought came to my mind.
Sure.
What is this tumor, the endobronchial lesion? I mean, at some point I thought like this might be Steven Johnson triggered by HSV, but I can't explain the endobronchial lesion, and also there's no cutaneous involvement, no CNS involvement. You said, right?
Right. Yeah, I think it's kind of a unique presentation, and I was going to present some of the literature about it, but it's quite, I guess, acute and fast progressing and kind of mass-like lesion, which is not the typical thing we see, and that's kind of another challenging aspect of this case. Yeah. But I guess he kept basically bleeding. The next day, he went into another episode of high peak pressure and clots, and unfortunately, he went into cardiac arrest. They tried to suction, and basically, almost 300 mLs of blood came out, and tried with bronchoscopy to dislodge these clots and what looks like another soft tissue kind of growing mass, and that did not work well until eventually a piece of it came out and he was able to ventilate. But at this point, like it took over an hour of resuscitation and significant hypoxia throughout the period, and patient was in severe shock, like 4 pressors, and pupils were dilated and reactive. So given everything, and the decision was made to withdraw care, and the patient expired. The tissue that came out of that area, and which is kind of like the really atypical picture, so sent to the pathology, and basically here what we see, you see these pink cells here, which are ciliated bronchial columnar cells with viral cytopathic changes. You see the nuclei unenlarged and with clearing out, as well as multinucleated and peripheral margination of the chromatin. And in the background, you see red blood cells and mucin. Here, a closer look, you basically see what we described before, the margination of the chromatin and molding of the nuclei, kind of pressing against each others, and viral nuclear inclusion, pushing the chromatin to the outer edge of the nucleus. And this is the HSV immunohistochemical stain, which was strongly positive in this case. And along with the cytopathic changes seen, they felt that was very typical for HSV. Just to confirm, like sometimes adeno can look the same, so they did the adenostain, which was negative in this case. So with that, I wanted to kind of do a review of a few things. So one is HSV laryngitis tracheitis. How common is that, and is that really seen? And 2, what about this kind of tumor-like lesion that we saw? And then touching a little bit about HSV resistance. So, I mean, when you look up the literature about HSV laryngitis and tracheitis, there is really very little out there, basically case reports and case series. So this is, for example, a 54-year-old well-controlled HIV patient who had a significant, who was an inhaled steroid. And apparently he was also taking itraconazole for ABPA, probably kind of boosting the dose of his steroid systemically and maybe causing more immunosuppression. So he came in with progressive hoarseness of voice, and you can see here the vocal cords are involved. And then they did a biopsy which confirmed HSV cytopathic changes and immunostain. And then the trachea, you see all these vesicular lesions, which also they did a brush biopsy that was positive for HSV. And after treatment with antiviral therapy for 2 weeks, all the lesions have resolved, and he did well. And this is the cytopathic changes that they saw with the cytology. And then this is another review article. They looked up the literature. They found 36 patients with HSV laryngitis up till 2020. Half of them were peds, half were adults. In children, the most common symptoms or presenting symptom was stridor, while in adults was dysphonia and dysphagia. And adults were more likely to undergo tracheostomy. And then they looked up the clinical characteristics and outcomes, and they found that, as we said, stridor in kids, dysphagia, dysphonia in adults, and I guess with the kids, most of the time they actually got to the type 1 and type 2. In adults, usually a lot of them were unknown type. They just quantitative, qualitative, I guess, HSV without subtiming. And this is just kind of the management and intubation between the two, with tracheostomy being done mostly in adult. So it does kind of, I guess, HSV usually we see it most of the time in the oral airway, or like the lips or the oral cavity, but I guess as the disease progresses, it can progress deeper there. And then the second question about the can HSV really cause tumor-like lesions. And looking up the literature also, I found this review of HSV mucocutaneous tumoral lesions. And patient age range from 7 to 76 in this cohort, and mostly were males, 2/3. 88% percent were HIV related, and then some of them involving the facial lesions, including the mouth and oral cavity, and the starting like symptoms, and then others were kind of in the genital lesion. And this is another one showing as a case report with the HSV presenting as supraglottic mass. And a patient was treated. He had secured his airway, and they treated him for HSV, and the mass eventually resolved. This one also had a group A strep, so they treated, I guess, both, and things got better. But it was a 69-year-old woman presenting with a stridor, and then they have this large mass. She underwent urgent tracheostomy, and the biopsy was positive for HSV immunostain. Another case report about an endobronchial lesion with a fungating mass. It was in the right bronchus intermedius, at just the branching point of the right middle lobe and the right lower lobe area. And they did a biopsy, which basically showed extensive ulceration and abundant granulation tissue and necrotic debris. And then they show HSV cytopathic changes that we show here. Similarly, another tracheal pseudotumor caused by HSV in a case report here of 75-year-old male who was a smoker. Otherwise, no significant immunosuppression, presented with cough, and then they found these lesions, which was confirmed to be HSV. So, I guess not a lot, but I guess there is some precedence in some cases with presenting, although most of them were not as acute as ours. And then touching a little bit about the management of acyclovir resistant HSV. So usually in the past, acyclovir was used only for treatment, but then a landmark study at the NAGM in the early 80s showed that prophylaxis was associated with significant reduction of infection in following allogeneic stem cell transplant. And this was a randomized clinical trial of an N of 20 that was published in the NAGM. Basically, it showed that if you don't use acyclovir, you have 70% risk of infection, while if you use it in this cohort, the risk of HSV was 0. And then it became the standard practice. And as people start using more acyclovir for prophylaxis appropriately, then we start seeing more of the resistant HSV. as the virus is replicating during periods of immunosuppression. And reviewing a little bit of the mechanism, so acyclovir basically is a it kind of has to be taken and incorporated into the DNA sequence, and then it terminates it. But the thymidine kinase can undergo mutation, and then either doesn't take the acyclovir or thymidine kinase negative strains. So it kind of overcomes that. And then we have the phoscarnet that act on the DNA polymerase itself and can lead to resistance. So it is an emerging concern, especially among stem cell transplant. This is a French study. They noticed that the median in this single center study, the median interval between stem cell transplant and first clinical manifestation of the acyclovir resistant infection was around 30 days here, and it developed in 7% of their patients. And transplant from a mismatched donor was a risk factor, and almost 80% developed extensive oropharyngeal disease, and one had interstitial pneumonitis. And then looking at therapy, they found really poor response to therapy with resistance to acyclovir and phoscarnet. If you have resistance to both, then they develop all clinical failure. However, if you have in vitro susceptibility to phoscarnet, like our patient, they still noticed a good clinical response to in 70% of patients. So you have still 30% who do not respond compared to cidofovir, where the response was much lower, 43% of patients. And then this study looked at the development of drug-resistant herpes infection after haplo-identical hematopoietic stem cell transplant. And basically, haplo became a thing because in the past you have to have significant matching, but it was a lot of patients were not able to be transplanted because of that. So then came up the idea of if we just have half of the match, basically from your family members, parents, or kids, then at least they have half of your DNA. Then you can still do the transplant with immunosuppression. But you can imagine with the increased mismatch, there is going to be more chances of requiring higher doses of immunosuppression, and subsequently that can lead to more complications. So, and this is, they noticed that out of 14 patients, half of them developed HSV infection, half did not. And the ones who develop HSV infection have lower CD4 count at day 100, which is in the middle here, compared to the ones who did not develop HSV. So, and the risk factors, basically they have, in this study, 36% of them were acyclovir resistant, and risk factors for resistant HSV were prolonged immunosuppression, lymphocyte depletion of the graft, and haploidentical, much more common than match unrelated donor. And they noticed that about 60% of their resistant patients had phoscarnet resistance too. And in many cases, even with the sensitive ones, the lesion persisted throughout the antiviral therapy until the lymphocyte recovery. So it's not just a chemical antiviral treatment alone is what's kind of important for cure, but it might stabilize things, but you really need the immune system to come back for the patient to completely recover. And then in this study, they looked at delay of alternative antiviral therapy and poor outcome of acyclovir resistance HSV in recipient of allogeneic immune cells, allogeneic stem cell transplant. So basically, they found in this cohort 18 patients with acyclovir resistant HSV between 2002 and 2014, which is less than 1% of their overall population. This was an MD Anderson study. And then they noticed that pre-engraftment period or steroid therapy for GVHD were risk factors, and then complications included renal failure and hospitalization, and they required very long durations of therapy, like 80 days. And they looked at those who had response, clinical response versus not, and they noticed that match unrelated donor patients have more response, and then AML patients, I guess, were more likely to have no response. And then the median absolute lymphocyte count at the time of diagnosis was also lower in the no response to therapy. So how do we treat patients with suspected acyclovir resistance HSV? In this population, they have like 1/3 they got foscarnet, have foscarnet resistance, and but overall they have slow or no clinical response to therapy, and the few patients responded to IV acyclovir or high dose IV acyclovir despite phenotypic resistance, but overall high mortality, like 50% mortality. One patient also died due to hepatitis. What do the guidelines say? There is no clear guidelines for like transplant patient, but if you extrapolate from the HIV guidelines, there's the CDC HIV guidelines for acyclovir resistance HSV treatment. So the preferred therapy is IV foscarnet with alternative therapies, including IV and topical cidofovir, as well as topical imicumab, foscarnet, and trifluridine. But as we saw, like this in the previous thing, I think if you don't get immune recovery, I think you're still in trouble. If the infection is extensive and the patient has high resistance. There is some new hope for a new drug because all of these drugs are quite toxic, like foscarnet and cidofovir are both nephrotoxic, and if you had another organ failure, the odds of survival will be much lower. So a new drug that's coming is pritelivir, which is well tolerated, and it's a helicase primase inhibitor. And in this phase 2 trial from 2013, published in JAMA, they noticed that when they compared it to acyclovir for genital lesions, there was overall less shedding of the virus, and days with the lesion were lower in the pritelivir, and as well as days with pain. This, however, was the phase 2 trial was terminated early because of they got some non-clinical data, like showing, there might be some toxicity in animal models. The data just came in at the time of the trial, so they ended up halting the trial. So it's kind of terminated early, but still they have almost like 150 patients. But the company went ahead and did a phase 3 clinical trial comparing it to IV foscarnet for acyclovir resistant HSV. And there is an expanded access program is actually available for that. It's an oral agent. And actually, I was updating this presentation. I found that just 2 weeks ago, the company published some like news report about the preliminary results of their phase 3 trial, showing that it actually was superior to foscarnet in their phase 3 trial for acyclovir-resistant HSV. And they basically, the comparison was to standard of care, whether it's foscarnet or cidofovir, depending on the provider preference. And they found that the significant reduction, significantly lower toxicity. It was like 40% in the standard of care group compared to like single digits % for the pritelivir. So I think the publication should be hopefully coming the next, it's probably submitted somewhere, but it's not published yet. And they said that they're submitting application for FDA approval in 2026. So in conclusion, laryngitis and tracheitis are rare but serious complications of HSV. Early recognition is key. Airway management, tracheostomy may be needed in severe cases. And then acyclovir resistance and profound immunosuppression might compromise response to therapy. With that, I will stop and be happy to take any questions.
Thank you, Yasser, for the interesting case and a nice presentation of a review. Any questions? The floor is open. Yes, did you find any similar cases in immunocompetent patients?
I mean, some of the patients with the tracheitis, laryngitis were like relatively immunocompetent, maybe a little bit older patients like immunosenescence, but usually they were not as severe as this case and not as rapidly progressive as this one. It's really a sad case, and because this guy was, I mean, he was having recurrent infection, but had a transplant to cure his immunosuppression and ended up fortunately dying as a complication of that. But looking in retrospect, I'm not sure like what else could have done to prevent this. Like, but it is really a challenge. This hopefully with this new drug, if we have additional tools added to the armamentarium we have, then that might be helpful for future cases.
I think the fact that this kid has been immunosuppressed, like with primary immunodeficiency from early childhood, being exposed to acyclovir multiple times, that's corresponding to unresistant acyclovir-resistant HSV infection. Yeah, so his program was bad from the beginning, for sure.
Right. And I think you guys in peds, you see this more often. I mean, in the adult side, I've seen like, I would say handful of cases of like really very extensive resistant HSV. That's clinically significant like that. But usually, you kind of like, unless you were able to fix their immunosuppressive issue, because otherwise they're just going to keep, developing through different regimens, and eventually they become resistant. And then you ended up with a complication of therapy and renal failure from the foscarnet and the cidofovir. So it's a tough one.
It is very tough one. I think for CMV, I came across one case, CMV resistant, like ganciclovir resistant CMV infections. They used a very unique way of using T cells targeted towards that virus to help clearing the virus, and it worked. But I'm not sure if there is anything for HSV. Like
HSV. Yeah.
I'm not sure.
Yeah, CMV resistant we see quite a bit in adults, especially with the transplant population. And yeah, it can be also, tough to treat, but sometimes, like with transplant population, you reduce the immune suppression, you play with a few things, and sometimes just like depending on the mutation, you give high dose of the ganciclovir. But yeah, I'm not sure about the T cell therapy for. I haven't come across anything for HSV.
Okay, sir.
All right, if there is no more questions, we'll conclude our session today. Thank you very much, Yasser, for the excellent presentation. And we'll hope to see you all next month with a new session.
Thank you all.
All right, thank you. Take care.